Hey guys, welcome back to the FOAMfrat podcast. I had an interview with Dr. John Ling after a discussion on Facebook regarding pelvic fractures. And Brian has a talk that he's been doing for our live classes inside studio on pelvic fracture. So I wanted him to come on and just do a little introduction. Brian, you listened to the interview, kind of challenged some of our previous thought processes. What was your takeaways at the end of it?
Yeah, I think it's super interesting because historically we've always been taught with pelvic fractures, especially as was mentioned, probably over the past 10 years, that we're not putting pelvic binders on correctly. They're typically placed too high, and I think the traditional feeling was hey, we're putting these pelvic binders on, and we're putting them on in the improper place, or we're not putting them on at all, and it's contributing to mortality. For not putting them on or putting them on improperly was the two big takeaways, historically. And then what they're finding now is that, all right, how big of a difference does this actually make? And I think one of the most interesting things was he mentioned, some medical directors are looking at, hey, are these even worth it? Mm-hmm. Should we even be placing them? And, they're obviously not inexpensive either. So it's really challenging what we've always been taught over the past, 10 years.
Yeah, I'm curious to see if before EMS services or medical directors go, yeah, we're going to throw away these pelvic binders, if they're going to want to see some more position statements from other areas, other entities as well, or if this is good enough. Because this isn't like some new randomized controlled trial that just came out, right? But it is taking all the information in the past and then actually looking at it. And so I don't want to give too much away before we actually get into the interview. But the main takeaways from your pelvic fracture class are really how the pelvis fractures, how it breaks, and how to apply a pelvic binder correctly. Is there anything else that you think would help preface this discussion as we go into that based off of the talk that you give?
Yeah, I think there's a couple of things that are incredibly important with this. Is number one, we've always sort of looked at pelvic fractures as a high source of bleeding. And, we look at that, and traditionally it appears that most of this bleeding is venous. It's, 80 to 90% of pelvic fracture hemorrhage is going to be venous, while the remaining, 10 to 20% is arterial. And I think this is a big push to why the pelvic binders really made sense. You're decreasing the volume from these open book pelvic fractures. And when you decrease that volume, especially with venous hemorrhage, you're able to, create a tamponading effect. Now, there was a couple of things, obviously, you posted on social media about, how are the feet positioned, and you guys get into that during the podcast, but that's something that I've never been taught. And, what we saw on social media was that exact same thing, as most people had never heard of this, except with the exception of a femur fracture. But I think there's a lot to take away from this. And obviously it's going to be very interesting to see where things go from here after people start really diving into this position paper.
Yeah, and the other thing that I just wanted to bring up, because when you first listen to rotational instability versus vertical instability, it can be hard to wrap your head around what that means. So rotational instability is it opening on its horizontal axis. So if you're listening to this, imagine the way you open up a book, right? That's like the open book fracture, where vertical instability would mean one side of the pelvis can lift up or down. So it can go, superior or inferior. And so the way the ligaments attach us, I think of it like a hula hoop, except instead of one continuous bony structure, you have bones and then you have ligaments in between, keeping the integrity of the pelvis. And so the different classifications, the Young-Burgess classifications of pelvic fractures, they look at the ligament damage as well as the actual bones, because you need both of those to keep that structural integrity. And as we mentioned in the podcast, the anterior-posterior compression seems to lend itself more to the rotational instability, where it can open up. And that's probably the one that would benefit more from a pelvic binder as opposed to something like a lateral compression, where, like you mentioned, somebody's walking through a crosswalk and they get hit on the side by a vehicle. So just so when we're listening to, or when you're listening to this, you have an idea of what those two terms mean. All right, let's roll the episode. Thanks, Brian. Dr. John Ling, welcome to the podcast.
Thank you.
I reached out to you because Jeff Jarvis dropped a bombshell on a post that I put up on Facebook about pelvic fractures, and I was trying to understand people's mental flow of like when they're applying these. Are they actually palpating them? Are we just applying them because of mechanism of injury? And then he said that there was going to be a paper coming out.
Yeah, so part of the NAEMSP Trauma Compendium.
Yeah. And so he said the paper was coming out, and then the comments in there kept going and going. And then you said, hey, the ink is still wet. You posted a link to a position paper, position statement from the NAEMSP, which is the National Association of EMS Physicians. And it was eye-opening, man. It was very, very well done. And so I wanted to, before we get into some of the nitty-gritty, just see what the motivation was behind that. Because you guys just did one on femur fractures not too long ago, and now you have one on pelvic fractures. So give us a little inside scoop on how that came to manifest.
Yeah. Well, so I'm actually the editor-in-chief for the entire Trauma Compendium, which we started a couple of years ago. You might be familiar with the compendium project that NAEMSP did on airway management back in 2021.
Yep.
And I was part of that effort as well. And we felt like we had such good success with that, and found some ways to maybe even improve on that, including being more robust with how we were conducting our research and reviewing evidence and such. And we looked at the entire library worth of position statements and resource documents that NAEMSP has put out, and felt like, so the impetus for the airway one was that we had all these bits and pieces of airway management over a number of years. Several of them needed to be updated, and we decided, let's just do a focused project on airway management and call it a compendium. And once we did that, then we decided, you know what, we've got all these bits and pieces of trauma management in the pre-hospital setting that are kind of piecemealed and cobbled together, and some stuff is pretty old and needs to be updated. There's some important topics that we haven't even looked at. So we formed a group of people, really smart folks like Henry Wang, Dave Cohn, Jeff Jarvis, and Nicole Bosson. I'll leave people out if I can't try to keep naming them, but and came up with 18 different papers that we have in the trauma compendium. Now, some of that includes like our methodology that we established across the entire compendium. So Christian Martingale and I published a paper on how we decided to conduct our structured reviews and evidence review and stuff. We didn't have the budget or the time to actually do the full-on grade methodology for any of these, because if anybody's done any of those projects, you know that's a really heavy lift. But we tried to be as true to the science and robust and thorough as we could with searching for the evidence and reviewing it. So some of those topics in the compendium were related to things we've previously published on from NAEMSP and had position statements on before. And for stuff like femur fracture, pelvis fracture, pneumothorax management, those were all topics that I thought were really important because we haven't issued guidance on them. And in looking through different forums and social media and stuff, it seems like those were things that people were always having questions about. And it seemed like there was a lot of dogma. It seemed like there was a lot of practices that people were carrying forward because they heard it from a lecture, who heard it from a lecture. And I'm part of that too. I started my EMS career back in '97. And I remember somebody telling me a lecture that you can lose a liter worth of blood in the thigh if you have a femur fracture. And I remember hearing that if you have a pelvis fracture, that you can lose a huge volume of blood into the pelvic cavity. And I've just repeated that over the years. So as we went into this trauma compendium, specifically with the pelvic fracture and femur fracture papers, I decided let's go back to the beginning and really go back to where did these ideas even come from? And then let's look carefully at the evidence that exists or we found that didn't exist to support any of these practices. And then to carefully look at so how those practices got started, and then to more carefully look at, do these practices actually make a difference? As well as if we're doing the practices, how good are we at doing them?
Were you surprised with what you found after doing like a pretty dedicated research? Because like you said, you hear things like if you were to pin me down on what I was taught about pelvic fractures is that we suck at feeling for them in the field. You probably like I was taught to do an anterior posterior compression once, and if you feel it's unstable, keep your hand there and then put a pelvic binder on. But the
Right.
reason we were putting it on was to try to contain the amount of volume of blood that can accumulate there. So
Right.
with that kind of framing, I mean, did this surprise you after you did this research?
So, I mean, you touch on a number of topics or subtopics that we looked at pretty carefully with this paper. Um, and we can take them in any kind of order. But to me, a lot of us have been putting pelvic binder on, myself included. I trained my crews when I was medical director of the ground and air ambulance service here in Minnesota for almost 10 years. We put pelvic binders on all the trucks and all the helicopters because we were just following along with the rest of the flock that, hey, this is something that's important. We should be doing it. Pelvic fractures equal severe bleeding. So if you've got a hypotensive trauma patient with a significant mechanism, then you should put the pelvic binder on because that'll prevent bleeding.
Mm-hmm.
But when you look at the literature and actually ask the question, do pelvic fractures result in actual bleeding? So we're looking at, is there a causation relationship, not just an association relationship? And yes, there are some pelvic fractures that can result in peripelvic vascular injury. But the majority of pelvic fractures actually aren't associated with severe hemorrhage. Let me say that again. They are associated with severe hemorrhage, but they are not causative of severe hemorrhage. In most cases, we found in the literature review, if the patient had a pelvic fracture and they were hypotensive because they were bleeding somewhere else. They either had significant external hemorrhage or they had some type of intra-abdominal hemorrhage, but not related to a peripelvic vascular injury. So it was an injured spleen, an injured liver, some sort of other vascular tear further up in the abdominal cavity or something retroperitoneal.
In addition to the pelvic bleeding, or there was no pelvic bleeding associated?
So either there was no pelvic bleeding actually found, or the pelvic bleeding was not significant enough to actually cause hemorrhagic shock. So the literature that we looked at was, to me, it suggested more that if you are suspicious for a pelvic fracture in a hypotensive patient, there are a couple of ways that you can follow that garden path down the wrong path. So if you have a hypotensive trauma patient and you just think, okay, well, they maybe have a pelvic fracture, we're going to put a pelvic binder on them, and you stop there, that's a bad thing because chances are the patient's bleeding from something other than the pelvis. So if you stop your search for the bleeding at, well, maybe they've got a pelvic fracture, I bound it, I can move on to other stuff, you're probably missing the true source of bleeding.
But you can't really do anything about bleeding. I mean, you're still giving blood, right? You're still doing TXA. And if somebody's got a splenic lac or a liver lac, I mean, there's nothing else you can do except fly to the hospital, right?
True. So yeah, you're giving TXA, you're giving blood products. If you've got blood products, there's good evidence and growing evidence to support the use of pre-hospital blood, and all for that when you've got it available. But the pelvic binder isn't necessarily doing what we think it does. So, so that the first question was, do pelvic fractures result in actual causation of hemorrhage, or are they just a marker for other sources of hemorrhage? And the literature we found was that more often they're a marker for a different source of hemorrhage than actually being the primary source of hemorrhage. Okay. So if we think about this as, well, let's start with the prima facie case of pelvic fracture equals bleeding from the pelvis. Then the next question is, does placing a pelvic binder improve the patient outcome? Right? Is the intervention we're doing having the cause and effect, having the effect that we want it to have? Excuse me. So when we looked at that part of the literature, does placing a pelvic binder improve patient outcomes? We found that no, it doesn't seem to have any impact on patient outcomes. Then the next question would be, well, is it because we're putting it on the right way or not?
Mm-hmm.
And there's plenty of literature out there that shows we do a crap job of putting pelvic binders on patients. So completely ignoring whether or not we can identify a potential pelvic fracture in the field, which is really hard to do, if we're just empirically putting binders on patients, we're often, more often than not, putting them too high. So not over the trochanters, we're putting them over the iliac crests. And actually, if you put them in that place, they can worsen certain types of pelvic fractures. So we're actually causing harm in that setting. Excuse me. So even if pelvic fractures are causing significant hemorrhage, applying a pelvic binder doesn't seem to be improving the outcomes down the road. Several papers we looked at said it did not change the volume of blood that the patients needed to be resuscitated with, either in the pre-hospital or emergency department or hospital setting. Didn't change the amount of crystalloid that they might receive, didn't change the length of hospital stay, didn't change the length of ICU stay, didn't necessarily impact what was or wasn't done for additional hemorrhage control in the hospital, like if they needed to go to the OR for pelvic packing, if they're doing an XLAP,
Yeah.
or if they're going to interventional radiology for directed catheter-directed embolization, things like that.
Would you say that like looking at all cause mortality is probably a harder thing to look at because the amount of force required to fracture somebody's pelvis is going to be concomitant with other injuries as well, so
Exactly.
there was a paper you guys quoted in that, or a study you guys quoted in that paper that talked about a transient increase. It was like 15 millimeters of mercury or something of blood pressure after a
Mhm.
pelvic binder. It wasn't a huge sample size at all. But I just wonder, if the data we have right now says, well, we suck at identifying when to put it on. When we do put it on, we put it on wrong, and then there's no evidence that it improves mortality. It seems like the first two kind of counteract the third because we don't really have any good data. And so as I was thinking about this, I'm like, well, what about you when you're working in the ER, right? So if somebody
Mhm.
comes in with a pelvic fracture, maybe EMS brings them in, they haven't put on a pelvic binder.
Mhm.
I wanted to know, are you shooting films before you put on a pelvic binder? Are you even going to put one on? What does that translate to how you do stuff in the ED?
Even in the studies that we looked at where the pelvic binder was applied appropriately, it still didn't change outcomes. So
As far
you kind of
outcomes
mentioned that.
meaning mortality?
Yeah,
Yeah.
didn't change mortality, didn't change the amount of blood transfusion. So of course, if we do a poor job of applying the therapy, then that might be the problem in terms of we have a bad outcome. Well, it's because we didn't put the binder on correctly in the first place, which
Hmm.
that's part of it. But even when we look at the cases where the binder was applied appropriately, it still didn't have the downstream effect that we wanted it to have. So to go to your next question about what do we do in the emergency department? So I work in a level 1 trauma center. I work in a community hospital. I work in critical access hospitals. So I see trauma everywhere. I see it on the receiving end when we have the patients come into the trauma room, and I see it on the sending end when I'm seeing them out in the rural hospitals. And in 20 15 years or so of working in the emergency department. I'd say in the first 5 years or so, when I was a resident out in Syracuse, New York, we would pretty commonly put a pelvic binder on. Now, that was back between '05 and 2010 when pelvic binders were still kind of a new thing. They were novel. There was a
Hmm.
lot of interest in putting them on. So we were doing it more often because it was kind of the cool thing to do. We see that in EMS a lot. Some new thing comes along and everybody wants to jump on the bandwagon. Whether or not the hypothesis of this thing is helpful or not has been proven with evidence yet.
Hmm.
So I would say in the past 10, 15 years at least, I can count on one hand the number of times that I've actually put a pelvic binder on a patient in the emergency department. And that was pretty certain I could say that was after we had a pelvic x-ray in the
X-ray.
emergency department that showed an obvious open book displaced pelvic fracture.
There's a podcast called the Nailed It orthopedic podcast, and like sometimes I like listening to podcasts that are like
Yeah.
outside of like our specialty just to hear how they talk about stuff. It's a little bit older,
Right.
but I was curious working in a level one where you can have the ortho guys come down and you can be consulting with them and talking with them. What's their consensus? How do they feel about it?
Yeah. So seeing an orthopedic surgeon in our emergency department is about as rare as seeing an ophthalmologist in our emergency department.
Even at the level one?
Yeah.
Oh,
If
really?
you, yeah. I mean, they'll come down occasionally. I've had them come in for some really severe cases, but most of the time we're doing a phone consult. They're looking at the X-rays remotely or in the doc's lounge or something like that. But they're not usually in the trauma bay with us. It's me and the trauma surgeon and the rest of the staff. But there was a time recently where we actually did have a orthopedic trauma surgeon with me and the regular trauma surgeon, and all three of us were standing there looking at the patient, and we raised the question like, "Do you want to put a pelvic binder on or not?" And he said, "Nah, we don't need it." Now this wasn't a horribly displaced pelvic fracture. I can't remember the exact details of how things were broken, but it wasn't like, oh my gosh, everything is completely smashed all to heck. And that patient, I think, went for an X-lap and had some other source of bleeding controlled that wasn't from the pelvis.
Yeah, I was looking at the Young Burgess classification system, from
Uh-huh.
like the 80s, 90s, and so like the Dr. Young had originally been like trying to correlate AP with lateral. He was trying to say like if you get hit like this is the predictable injuries that you'll have.
Right.
And then Dr. Andrew Burgess came in and said, and here's the gradient. Like depending on how hard you get hit, you could be from anywhere from like an APC1 to APC3, which is like completely, unstable. And with that, they correlated the amount of blood that they typically would get depending on that injury.
Hmm.
And so I heard that quoted inside that Nailed It Ortho podcast, and I was like, that's interesting. So they're saying, like, if you get this type of anterior posterior compression and you are rotationally unstable, you're more likely to get this amount of blood. So that's why when I saw this position statement say, well, it doesn't necessarily mean there's bleeding, when I look at my little anatomy app and you look at all the vasculature inside the pelvis, you're like, holy crap, the venous plexus and going through the sacrum. It just seems very interesting that you would get very little bleeding from a fracture. Now, I could see if you have an iliac crest, fracture or something like that.
Hmm.
But I was always taught like the majority of the pelvic bleeding is venous in nature, just because of the venous network and, like I said, the venous plexus.
Yep.
It just seemed interesting that you would not have that much bleeding because I was taught you could lose your entire blood supply into your pelvic vault and the retroperitoneal space. So
Yeah.
do you think that that's not true, that you really couldn't lose your entire blood supply into your pelvis, or that just is very odd, or would be rare, I should say?
I think from the literature we reviewed, that would suggest that that's an extremely rare case. Now, some might argue, well, even if it's a rare case, we should still be trying to, control hemorrhage in that case. So some might say, then, yeah, we should just still be putting pelvic binders on anybody based on mechanism of injury. But we have to be careful about how we apply therapies in medicine, right? Um, and this is a little bit of just a parallel thought process.
Mm-hmm.
If every patient that came in the emergency department with a cough, if I just said, you know what, there's a pretty good chance you've got pneumonia, I'm just going to give everybody antibiotics. Okay, so in that case, we're significantly over-treating the population who's coming in with the symptom, right?
Mm-hmm. With
With an intervention that's probably not going to help, because lots of cases of pneumonia are actually more of a viral bronchitis rather than a focal infiltrate on the chest x-ray. Okay,
Mm-hmm.
so if we just empirically treat everybody with antibiotics just because they have the cough and not do additional testing to confirm that the cough is from a pneumonia, we're going to be over-treating patients, and the downstream consequences of that are antibiotic resistance and side effects from the medication with rashes and allergic reactions and diarrhea and stuff like that you can get from antibiotics when you don't need them. So we have to be careful about just empirically doing things in EMS too, like
Yeah,
just
I agree.
throwing on a pelvic binder on a patient just because we're concerned about the mechanism of injury. Now, there were a couple of papers, and I apologize. I can't think of the author's name, the lead author's name for this,
That's
but
right.
there
I'll
was.
put it in the show notes, all the
Sure.
authors and all that. Yeah.
So, one of the papers that we looked at for the compendium or for this pelvic fracture paper was about the pelvic peripelvic or the pelvic vascular injury score, to see if there were things that we could find in the pre-hospital setting. So, not using X-rays, not using CT scans, stuff that we can use from what we can see and measure in the ambulance and in the ditch. Are there things we can identify objectively that we can put into a scoring system that can help us predict the patients that might have a pelvic fracture that actually is associated with vascular bleeding? And that's a tool that I felt was actually pretty important and could be really useful. It's not been widely adopted, but I think that's something that we should be looking at much more carefully.
Do you remember some of the criteria?
What's that?
Do you remember
Oh,
some of the criteria?
not right off the top of my head. I could probably pull it up
That's
here
all right.
really
That's not,
fast.
I wasn't sure if you had an idea of some of the things that they look at, because there's going to be a group of people that read this and say, yes, this is practice changing. We're going to get rid of them. Right. Do you think that that's accurate? Would you say that this is a practice changing position statement? Or do you think that it's just more of a, actually, I'm not even going to give you another option. Is this practice changing or not? What do you think?
Yeah, I think this could be practice changing. In fact, one of the so if we go to just the crib notes version of the whole position statement resource document. So people who go look at this document, the first part is going to be the abstract, and that has our bullet point recommendations. What does NAEMSP believe based on the evidence? And then the second part is the resource document where we dive deep into the evidence to support each one of those bullets. So we actually say in one of those bullets that pre-hospital use of pelvic circumferential compression devices or pelvic binders should be reconsidered given lack of proven clinical benefit, including insufficient evidence that they reduce traumatic hemorrhage or mortality, and because they have potential for causing iatrogenic injuries. So, in talking with my good friend Jeff Jarvis, he's looking at this paper as an opportunity to say, you know what? I'm actually going to stop using them in my service. And I think that's a reasonable approach. I think it's still reasonable for people who aren't as convinced by the evidence. If they want to keep using them, that's perfectly fine. But this paper also goes into if you're going to keep using them, make sure you're using them in the right way. So putting them low over the trochanters, not high over the iliac crests. Binding the feet together, so getting the feet internally rotated, because that helps close the pelvic volume as well, and you could actually make a reasonable argument that you might not even need the pelvic binder if you can just tape those feet together so the big toes are touching. That might be enough if there isn't some other disruption in a femur fracture or something, to help reduce the pelvic volume by doing that without actually putting a binder on.
Yeah, that was an interesting point, because I'm sure I tagged you in it when I posted it on Facebook,
Yeah.
but I don't remember learning that. And I went to like the pelvic binder commercial tutorial, and I sent you that screenshot, and the
Right.
feet were like, like this. And
Yeah.
I was like, man, and did you see the comment? A lot of EMS providers in there going, I was never taught that. I was never taught to put the feet together. It makes sense. I'm not the one coming up with the decision whether we're going to keep doing this or not in the field. That's our medical directors.
Yeah.
But my thought was, okay, we have some case studies, not a ton, that it could cause harm. We know that we are terrible at identifying these in the field. Does it biomechanically, does it actually make the pelvic volume smaller in an APC pelvic fracture injury? In the cadavers, it did it just as much as like a fixation device, right? That's what they said, is when they would actually fixate it compared to a commercial pelvic binder. I think you guys may even made the statement that a commercial pelvic binder is probably better than a sheet.
True.
But really, it was if you got somebody that's their blood pressure's in the toilet, right? They have a reason to have a pelvic fracture. Maybe they're bleeding from their abdomen. Maybe they have a positive FAST as well. It probably, if you're going to apply it, just make sure you're applying appropriately. And that's the setting where I probably would feel comfortable applying it. I'm not going to, if somebody's awake and talking to you and they're not complaining of pelvic pain, that doesn't make sense, to just put them on randomly on people.
Right.
But it's that crashing hypotensive patient that I still see, a lot of people applying these on because they can't rule this out. The patient's unconscious. Maybe they're intubated at this point. You're already giving blood products. And so if you're going to put it on, greater trochanters, put the feet together, and then maybe there's some benefit. You're less likely to do harm if you follow those guidelines as you guys put out.
Yeah, exactly. Just as a mechanism or an anatomic kind of way to think about this. So if you have a pregnant patient who is in labor and there's a shoulder dystocia, okay, what do we do to the patient's legs to try to open the pelvic volume?
Put it up by, bring it up to them.
Their knees are up by their ears. So we've significantly externally rotated the hips to try to get that pelvic volume to open. Okay. So if the feet are laterally rotated, it goes to stand that the pelvic volume is probably somewhat open, especially if you have an unstable pelvis. And if you think about a woman who is actually in active labor, their pelvis is also very pliable. It's not broken, but the symphysis pubis is really flexible. All the ligaments are extra flexible so that the baby can get out. That's by nature's design. In a trauma patient, things are flopping all over the place because something's broken. But if we think about how do we increase the volume of the pelvis to get the baby out, if we reverse that, how do we decrease the volume of the pelvis to keep the blood in? If we're following that premise, then it's again getting those feet internally rotated, and then consider whether or not you're convinced that putting some sort of circumferential binder on, whether it's a commercial device, which if you're going to do pelvic binding, commercial devices do seem superior to sheets. Sheets just lose tension. Sheets put increased pressure over specific spots that increases the risk for having iatrogenic pressure-related injuries. So having a commercial purpose-built device rather than an improvised device is probably a better plan.
It's like how you stand when you have to pee, you put your legs together.
Right. Yeah. You kind of put your knees together. You're trying to keep the urine in. So yeah, exactly.
Awesome.
So,
man. Go ahead.
Yeah. So going back to that, the pelvic vascular injury score. So figure 3 of the paper condenses that down. So they look at 3 different categories and score the whole thing up. Everything that's in each category is worth 1 point. And it looks at stuff like, is your age more than 70 years? Was it a high energy trauma? Is there penetrating trauma or an open pelvic injury? So you can see inside the skin and the internal stuff. Is there a shock index greater than 1? It looks at, so that's condition. If they look at intervention, is the patient getting CPR? Are we having to substitute more than a liter of fluid, whether that's blood or crystalloid? Completely different podcast. But if you're putting more than a liter of something into the patient, and whether or not they got intubated. And then their next part was recompensation. So are we having to give them catecholamines, so epi, norepi, or they're still having shock, even if they've received therapy. If you gave 1 point for each one of those things and add it all up, you have to score at least a 6 to have a peripelvic vascular injury to be very likely. If it's 9, so you get a positive for every one of those points, then a peripelvic vascular injury is apparent, according to this scoring mechanism brought up by Sparing et al. From 2024 is actually when that paper was published. So it's pretty new.
Yeah, no, I like that a lot. I think one of the pitfalls I've heard people say when they use ultrasound is like, oh, they got a negative scan in the bladder, so they don't have a pelvic bleed. And, that's just the pelvic extension of that peritoneal cavity. You still have the entire vault in there that they can be bleeding into.
Yeah. Yeah. To me, of all the different takeaways, if you're looking for patients that might have the most benefit from putting a binder on, with the assumption that a binder is going to help reduce bleeding from fractures of the pelvis that are causing bleeding, then following this pelvic vascular injury score, to me, seems to make the most sense to guide whether or not you should be spending the time putting a binder on. Because remember, if we're putting a binder on, there's also opportunity cost with that. We have a finite amount of time to do things in the pre-hospital setting. And if we're spending time putting the binder on, we're not spending that time doing something else, right?
How much consideration do you think we should give to the injury pattern? For example, typically anterior posterior compression, head-on collisions, you are going to get more rotationally unstable as opposed to vertically unstable. I guess once you get down to like the APC3, they can be both. But that open book or rotationally unstable seems to be like that's where you would get more volume in the pelvis. Now, a lateral compression, somebody gets T-bone, for example, those tend to contract in because of the injury pattern. So would you say you're more likely to probably see a benefit from if somebody has a head-on collision, rotationally unstable, they're probably going to be more likely to benefit from a pelvic binder than somebody with a lateral compression?
So that was another thing that we specifically looked at in the paper. Yeah, there was discussion because there are certain fractures that if you apply a binder, you can actually make things worse. So Toth and DeKaiser showed pelvic fractures or pelvic binders placed on lateral compression fractures worsened deformity. So Toth found that it worsened things in 11% of cases, and DeKaiser found it worsened things in 61% of the cases. So especially in those lateral compression fractures. So you're the patient that was minding their own business, walking through the zebra stripes, crossing the crosswalk, and they get tagged by an SUV with that lateral compression. Those types of pelvic fractures, mechanistically, you're going to have a high index of suspicion for a pelvic fracture in those patients. But the challenge there is it's probably a lateral compression fracture, which those two studies showed if you put the binder on, you can make things worse. You can actually distract the fracture more. And if you're distracting a fracture more, you're potentially tearing more of those bridging vessels and exposing more marrow and worsening the potential places where bleeding is going to come from rather than tamponading those things.
Awesome. Well, Dr. Ling, this has been very helpful. I appreciate your time coming on. Any closing statements, anything we didn't talk about that people should take into consideration when looking at this and deciding what to do with the information?
Sure. So, I think it's important whenever any of these papers come out that challenge some common practices and common thinking, it's important to read these papers carefully, read them with an open mind. That's how we entered into all of these trauma compendium papers. We entered into them by asking questions, but trying to ditch any of our preconceptions on whether or not something was beneficial or not. And then took a hard look at the evidence to see, does the evidence support the hypothesis? So there are lots of interventions that we have in the field that seemed like a good idea at the time. On a prima facie case, the logic seems to make sense that doing X would benefit the patient. On a prima facie case, it seems to make sense that if we use an X fix on a patient in the operating room who's got a shattered pelvis, that it improves mortality and it improves hemorrhage control and things like that. So why wouldn't doing the same thing in the field with something that is as close to being an external fixator as we can get, why wouldn't that benefit people the same way? And that's how this whole idea of putting pelvic binders on got started. Problem is, we threw the hypothesis out there. We adopted the practices very widespread, but we didn't take the time to actually look at the science, do the actual research, and investigate whether or not the intervention that we think is helping is improving the outcomes that we want them to. So we can look at that in pelvic binders. I looked at that with femur fractures. Michael Millen just got a paper out about spinal motion restriction and C-collars and backboards, which that's not a controversial topic at all. But those are all great examples of things that seemed like a good idea at the time and were quickly adopted into standard practice without actually having good evidence to support them. So I think it's really important that papers like this and other papers in the compendium and other papers published elsewhere that cause us to take a pause at what we're doing, carefully analyzing, is what we're doing accomplishing what we think it does? Kind of the Princess Bride. I don't think that word means what you think it means. So that's to me one of the biggest take homes for me from this whole compendium that I've worked on is challenge what we're taught, carefully evaluate the evidence to see if what we're doing is actually doing what we intend it to do. And in the case of using pelvic binders, there doesn't seem to be as much evidence that they benefit the patients as much as we think they should, even when they're placed appropriately. Increasing use of them just based on mechanism of injury is unlikely to translate to improving outcomes down the road. In fact, it probably increases the risk for iatrogenic injuries. And, going to the question of how do we identify pelvic fractures in the field, I think that's something I want people to actually read the paper and look at, because we did provide some pretty good evidence there. And I don't want to give everything away. I want people to actually click on the article and read it.
Yeah, absolutely. Well, thank you so much. I appreciate it. I will link to the paper in the blog for this, and yeah, we appreciate it, Dr. Ling.
Yeah, and the paper's open access. You don't have to get through the paywall or anything like that to get at it through pre-hospital emergency care. You don't have to be subscribed to the journal or anything like that for any of these trauma compendium papers. So
that's perfect. All right, thank you.
All right, thanks, Tyler.